I thought there was a picture of my dog up there again. Yeah, I think my dog will be fine. Wife's dogs are going to go crazy. Baby. So, aging process. I think we're recording. I hope we're recording. It looks like we're recording. But I don't see the little bar. Do you? Doesn't it usually show that little black thing? No? It looks like it's recording, so we're good. Okay, aging process. So, of course you're going to think osteoporosis, but there's actually a stage before osteoporosis. And it's called osteopenia. So normally when you look at bone density, they'll do a bone density rating. They'll look at your bones, and you have this nice dense bone like this. But with time, it starts thinning out. It gets lighter, almost more transparent when you look at it. So a normal bone density should actually be above 833 milligrams per cubic centimeter is what they rate it as. That's normal. When it starts dropping down below 833, they go, uh-oh. If it's under 648, then they say, oops, sorry. If it's under 833 but over 648, they say you have osteopenia. You have thinning bones. It's not bad now, but then they'll tell you, exercise more, take what kind of supplements? Calcium and vitamin D. Yep, so they'll make you take vitamin D. Vitamin C to build collagen in your bones to make it stronger. So they tell you to take these supplements. They tell you to exercise regularly. They want you to build the stuff back up before it's too late. If you keep decreasing more and more and more, and you get down below 648, then you actually have what's called osteoporosis. Then you can see this bone over here. You still have spongy bone, you still have compact bone, but the thickness of the compact bone is going to get thinner and thinner and thinner. The density, I guess, would be a good word for the spongy bone. There's less and less trabeculae, which means it's softer and softer and softer, which means it has more tendency to do what? Break, or even before breaking, it has a tendency to bend or smash. So if you've ever looked at somebody with osteoporosis really bad, what's their posture like? Tipped over. And if they were 6 foot before, what do you know at their height? Yeah, they're like inches shorter than they used to be. I'll actually show you a picture in a few. But you can see what's happening. Up there on the top, the compact bone, you can see it's thinning out. It's not that it's getting more hollow or anything, because the compact bone is not hollow, it's just getting thinner. So the distance from the outside of the bone to the inside of the bone is getting closer and closer together. And then the spongy bone, you can see how you have all the trabeculae here at the beginning, but now it's becoming less and less dense. And then with men and women, like you can see in the little chart down there, men and women, they both start progressing and the bone density gets lighter and lighter and lighter. The advantage that men have are what? We started with more dense bone. Yeah, our bone was thicker when we started. So we still, even in our 30s, we need to exercise. We need to make sure we're getting enough calcium and vitamin C and everything. It's not just women, it's men too. Here's one example of a bone. So here you have a vertebra, normal bone, and then as it becomes more spaced out, you can see the big gaps. You can actually see black space in here. It just starts squishing down, squishing down. So as you live and all this weight's pushing on your vertebrae, they start compressing. Unfortunately, your spinal cord will also have to start getting cramped in that little space, because if it's used to having, you know, 1.5 feet worth of space in the vertebral column, and now you're down to like 1.25 feet, the spinal cord has to get smashed in that space too. So other problems can come along other than just bone issues. And then here's the chart. So normal bone is at least 833, osteopenia is under 833, and osteoporosis is under 648. 3 stages. Normal, pre-osteoporosis, and then osteoporosis. And then you can see that bone density again. So that last picture we were looking at was actually vertebrae being compressed. And there are a lot of causes. It's not just genetics or not just aging. If osteoporosis runs in your family, you may have genetic tendencies for it, so you really have to be careful. But it could also be activity level, so you're not exercising enough or your life's too stationary. It could be because you're not getting the right nutrients, vitamin C, vitamin D. Maybe you're not getting enough calcium or magnesium or phosphates. You need all those things to build proper bone. If you don't have enough estrogen and testosterone, these are 2 chemicals that increase bone growth in puberty, but they also maintain bone density after puberty. So what phase in life do women have to really worry about osteoporosis? Menopause. Yeah, so after 30, their bone density starts decreasing, but now at menopause, there's no, what? Estrogen. So it's going to decrease even more rapidly. And the same thing with men. We don't have a technical menopause, or what some people call andropause. Anybody ever heard of that before? It's actually supposed to be the male version. There's a lot of debate on it. But our testosterone levels start dropping at 30. They go lower and lower and lower. And by the time we're in our 50s and 60s, our testosterone levels are so low that the estrogens are actually taking over in our body and start getting more feminine characteristics. So we need those chemicals too. Here's the next one. So osteoporosis, and I'm not going to make you remember all the different names, but you can see the different types. There's not just one osteoporosis. They go off of how is it caused. So some things like iatrogenic, what's that telling you? Yep, it's because of something the doctor did. What could the doctor have worked on that would cause you to have osteoporosis? Let's say if you're a woman. Could have been thyroid, right? Because it could be affecting your calcitonin, your parathyroid levels. Hysterectomy, exactly. So if you had something done to the ovaries, because the ovaries are producing estrogen. So if you had an ovarian cancer and you had those removed, you have to worry about osteoporosis because what just happened to your estrogen levels? Your estrogen levels dropped. Okay, so that's iatrogenic, things like that. Regional, based on what area of the body is being affected. Postmenopausal, I already mentioned that, it's because of menopause and the lack of what hormone? Estrogen. Glucocorticoid-induced osteoporosis. This is interesting. A glucocorticoid would be, if you take it over the counter, prednisone would be an example. In your body, it's called, anybody remember what it's called? It's the stress hormone. Cortisol. They're the same hormone. Prednisone is artificial cortisol. If you have too much cortisol, you're high stressed all the time, cortisol will inhibit the development of osteoblasts. So what's happening? The osteoclasts are outnumbering what's going on with the osteoblast. So glucocorticoid-induced osteoporosis is because your osteoblasts are being shut off because of the stress. Your stress response is saying, reroute all the power you can. It's like if you watch those old Star Trek movies. I don't remember this Enterprise, but they'd reroute all their power to the like phasers, or reroute all the power to the whatever shield thing. I'm not a Star Trek person at all, so I'm reaching on this analogy. But it's rerouting. When you're under stress, you're rerouting all of your energy you possibly can to what two organs? The brain and the heart, right? So you want those two first, and then third, you go to the muscles. When you're under a lot of stress, you're trying to reroute as much energy as you can, as much resources as you can to keeping the brain at peak performance to get you out of the stress position and keep your heart beating fast to get the blood circulating. So everything else starts slowing down. When you're high stressed, your kidney will slow down its function, the liver slows down its function. It'll actually make more sugar, the liver will. Your bones stop building the way they used to. Your immune system, it actually inhibits the way your immune system functions too. So when you think of corticoids or glucocorticoids, when people take that, it's increasing what's going on in their brain and their heart, but it's shutting down everything else, including bone formation. Right? And then age-related bone loss, so this is just a natural process. And overall, the cause, no matter what it is, it's all because there's an imbalance in formation reabsorption. So when they talk about the multicellular units, they're talking about your osteoblast, osteoclast, osteocytes. You have these little bundles of these things. Now they're going to more reabsorption mode. Formation's down, reabsorption's up, and you just keep decreasing and decreasing your bone density. And then the other major areas that if you have malnutrition, and with Cushing's, yeah, they're making way too much cortisol, which is the same as up there with glucocorticoid-induced. That was a good question. Yeah, with Cushing's is hypercortisolism, so they're making way too much cortisol, which decreases the bone building. And then here's just an example. So you can see the arched back, short height. And if this were her natural height here, with the progression, you can see she just keeps getting shorter and shorter because her vertebrae are being compressed during those stages. And then, anybody know what that's called when the back does this? Yep, kyphosis. Anybody remember the opposite that pregnant women get? Yeah, they call it sway back or lordosis. I feel like pregnancy just keeps coming up over and over and over again. Probably because I'm bringing it up. Oh, speaking of which, that's her calling. Oops, sorry. And then, yeah, weird timing. All right, infection. I just happened to look down and my phone was all lit up. So next group is infection. Paget disease is the first one. In Paget, they believe that we don't really know the cause, but they think that it's probably viral, most likely. They think there may possibly be some genetic links, but they think primarily viral. Right? And then what's happening in here is that it's massive reabsorption of the spongy bone. So their spongy bone gets reabsorbed really fast, and it gets replaced with really soft bone. So when you're looking at the bone tissue, it looks really, really weird. You can actually see here you have nice distinguished lines. This is all fuzzy. It's all soft, weird-looking bone. So if it's soft bone, what's obviously not going to do well? Support weight. Yeah, it doesn't support weight. More likely to break, so more likely to get fractures. When you get this, and you can see it's not staying within the normal lines again, it's kind of puffing out. So what bones might you think could be life-threatening if they started thickening like that? What part of the body? Maybe the ribs? Maybe keep thinking north? The branium, right? Did you just say branium?
No, I said cranium.
Oh, okay. I could have sworn I heard branium. That's a funny word. But anyway, yeah. So if the skull starts thickening like that, then you have to worry about it compressing the brain. All right. And then you can see some of the other problems. So it could cause problems with spine, the brain compression. It could cause deafness. Think of what bones could cause deafness. Yep, if it's ossicles, or remember the cochlea actually sits inside the temporal bone. It's in the temporal bone. So if the temporal bone starts doing that, compress the cochlea. So those are just some examples we're going to think of. The optic nerve, when it comes into the brain, has to go through bone. It can compress the optic nerve and cause vision problems. If it happens down at the pelvis or the waist, then you're going to see problems with, like hip dislocations and stuff. And I put the list of signs and symptoms, and for some reason they came out as bullet points like this, but the signs and symptoms are all under here. And we just talked about some of them. Next one's osteomyelitis. So osteomyelitis is an infection of the bone, which means you had to get some kind of infective agent like bacteria in there. So how this usually happens is not because it goes through the blood, but it usually happens because it's introduced through a wound, usually. It can get in from the blood, there's nothing saying it can't, but typically it's because if somebody got stabbed, they got their leg cut with a chainsaw. My stepdad, when I was younger, he slipped and cut his leg with a chainsaw and actually hit the bones, and they were worried about this. I didn't know what it was called back then, but it's because, if you get stabbed, most stabbers are not courteous enough to sterilize a knife before they stab you, right? So, and when they stab, they take the bacteria on that knife and they introduce it right down into the bone, and it goes right into the bone. If that bacteria gets in the bone, it's comfortable in there. Plenty of nutrients, so plenty of bone marrow. If it's fat, yellow bone marrow, there's all kinds of feeding in there. So it'll go crazy. And unfortunately, your bloodstream doesn't go in there as easily as it should. And all the white cells in the bone marrow are what? What do you know about them? While they're still in the bone marrow, they're immature. So, yeah, it's surrounded. It would be like me dropping you right in the middle of some military barracks, with a gun, and all these people that just got there the first day, and they're like, oh my God, what do I do? And they're running around freaking out. They don't know what to do. These white blood cells have no clue how to fight off this infection yet, so the infection just goes rampant and eat the white blood cells and destroy the white blood cells. So osteomyelitis is when it gets into the bone, the infection gets in the bone and starts destroying it. And here is an example. So yeah, here you can see the tibia just totally eaten away all the way through. Mm-hmm. So it almost looks like, doesn't it look kind of like a bone within a bone in this situation? Because it hollowed out the bone. It's not your teeth. Basically layers of bone. What were you going to ask, Barb?
Oh, so that's like what would happen in the medication that is also known, but
in the bone? Yeah. So if things like that get to the bone, it's really, really bad. And that's osteomyelitis. And because the circulation into the bone is not the best, I mean, it's there, but it's not the best, it's hard to get antibiotics in. So there's infection. That was quick. Nutritional defects or deficits. I don't know how to say that. What, obviously, are you going to look at? Vitamin D or what nutrients? things like calcium, magnesium, or phosphate. So the big one you want to pay attention to is going to be osteomalacia. We call it osteomalacia when it's talking about adults. When it's a kid, we give a special name, rickets. So it kind of revolves around vitamin D. If you're not getting enough vitamin D or you're not making enough vitamin D, then you can't absorb the calcium. Your bone's constantly breaking down to supply the blood with calcium, and then you just excrete that calcium out. So it's weak. And then what happens to the legs with kids with rickets? Yep, they bow out. So they're all intact. It's not like a bowing fracture. They're intact, but they bow out because all the weight of the top part of their body is pushing down and it's making them bow out. So they're not getting enough vitamin D. And in kids, it's called rickets, and adults, it's called osteomalacia. And they can get muscle pain, they can get bone pain, they can get joint pain. Their joints aren't going to be aligned, so they have a tendency to get more tears and so springs and strains. Another thing that can cause osteomalacia or lead to it would be imbalances of certain hormones. What hormones might be out of whack? Yep, calcitonin and parathyroid hormone. They could both be out of whack. Right. And then tumors. So tumors, this looks more complex than it actually is. When you look at the tumors, most of the tumors are named after the cell that it came from. So if you look as you're developing the different layers of the bone, if you look at an osteoblast, so what's the osteoblast doing? It's making bone. So we call those osteotumors. So osteoid, osteoblastoma, osteosarcoma, osteogenic, blah, blah, blah. It's an osteoblast. The tumors are rapidly replicating structure, right? So these osteoblasts make tons and tons of bone. They make these abnormal growths on the bone. And I have slides that go through each of them, but I'm just giving you the overview. What's a chondroblast mean? Cartilage. So you see more of the cartilaginous ends. Think near the epiphyseal plate, or at the very end, the articular cartilage. Wherever you see the cartilage, you're going to see the problem. And they call them chondro something. So chondrogenic, endochondroma, chondroblastoma. They have chondro in their name. And then the next one, the fibroblasts, they make collagen. That's the fibrous material. So a fibroma or a fibrosarcoma, they're telling you exactly the maker. Osteoblasts are osteos, chondroblasts are chondros, fibroblasts are fibros. And then these get a little bit tricky. But when you're talking about inside where you're making the blood cells, then you have specialized ones like myelogenic tumors. Myelogenic is referring to the tissue, in, well, basically the red bone marrow, tissue inside. We'll talk about those. And I was just doing this in physiology, but we were talking about different types of leukemias. So, bone marrow issues. Leukemias are when they're making too much of a white blood cell. What's an anemia? Making too few red blood cells, right? So, and then leukopenia would be making too few white blood cells, which we'll talk about later too. And then bone tumors. Oh, already did this. Oh, sorry. Here we go, the three terms. So when you're breaking down the bone, if you have a malignant bone tumor, it's destroying the bone. So what is that, by the way? It's now a bone cancer, yeah. So when it's malignant, we call it cancer. When it destroys the bone, if you look at an x-ray, there are three general patterns for the bone destruction. The first one is called geographic, and it's the least aggressive. They're really well defined in x-rays. They're least aggressive, and they're usually the easiest for us to identify and attack or treat. Try to cure. So they have this distinguished area. You can see where this abnormal growth is, and it kind of stands out from the rest. Moth-eaten is where it's actually being destroyed and broken down. So with geographic patterns, a lot of times you'll have this abnormal growth. It's not functional, it's not working properly, but with moth-eaten you actually see holes. It's like a moth-eaten piece of cloth where you have these little holes all over the place. Moth-eatens are more severe. So geographic patterns are usually slow-growing. Moth-eating usually happens pretty rapidly. And then the third one, permeative pattern. This is kind of like the worst of both of the others. So with permeative pattern, it doesn't look like moth-eating with big holes. It's actually hard to distinguish from normal bone, but it's rapidly growing and very destructive. So it's like moth-eating where it's rapidly growing, very destructive, but it doesn't leave holes like moth-eating, so it's more like a geographic. And then I'll just go through and tell you the main things you want to pay attention to here. And the first one's osteosarcoma. So what kind of cell is making this one? An osteoblast. Yep. So osteoblast. Usually you get it in people that are under 20 or over 50. So it says predominantly adolescents and young adults, and then occurs later in life. Usually it's before 20 or after 50. And these usually appear with moth-eating patterns. And sometimes in that holy area, holy moth-eater pattern, you'll have these little streamer areas that aren't actually calcified bones. They make them softer, they don't look quite right, and it gives that moth-eaten look. And here's an example. You can see you've got this destroyed pattern, and you've got all these little tiny holes and structures all over the place. So that structure is completely not a good structure anymore. It's penetrated all the way through the bones. Usually it starts with swelling and pain, and then just gets worse and worse. And usually the treatment is chemotherapy or amputation, because it's, you can just see it's destroyed the bone so bad that it's irreparable. Next is a chondrosarcoma, which is what type of cell? Cartilage cell, chondrocyte, technically chondroblast. And this usually, it's people that are older in age, 50 to 70. That middle age thing is kind of a touchy subject, where middle age actually happens. The older I get, I find it's later in life that middle age hits. And this usually comes on, these creep on really slow, and they usually happen around joints. Why around joints? Because that's where the cartilage is at, right? So you can see the hyaline cartilage, which is the articular cartilage. And then as it starts moving into the surrounding tissues, as it becomes a real cancer, it starts destroying that. So it usually hits in the 50s and 70s, between 50 and 70 years of age, and it happens in the chondroblasts. These things are slow, and they slowly creep up on people. They create what's referred to as insidious pain. It just creeps up on them slowly. Dull, achy pain. What kind of fibers would that be stimulating? C fibers, right? And then fibrosarcomas are what kind of cells? Fibroblasts. What did fibroblasts make again? The collagen. And the collagen, remember, gives structure to the bone. What makes these kind of interesting is that these have a tendency to metastasize to the lungs. And when we talked about cancers, I said that when cancer cells metastasize somewhere else, they usually pick somewhere else that's very similar to their home. So like breast tissue, because it's a lot of fatty tissue, it likes to metastasize to other places that have a lot of fatty like or lipid substances like the brain or the lungs. In this situation, you've got tons and tons of collagen around the lungs, you've got tons of collagen in the bone, so these things like to move up and move into the lungs with the environment's really comfortable. And then myelogenics. So myelogenic, we're talking about these bone cell producing cells. Like bone marrow cells, or sorry, blood cell producing cells. Right? So the giant cell tumors and the myelomas, these are blood producing cells. These have a tendency to metastasize because they have really easy access to what stream? the bloodstream. They get into the bloodstream, they can move anywhere they want throughout the body. And they have a tendency to make things called immunocytes. So myeloma makes things called immunocytes, which technically, the immature plasma cells. What's an immature plasma cell? What type of cell makes a plasma cell? B cells. So you've got these really weird B cell tumor or cells going all over your body. There are lots and lots of them, but they're actually pretty worthless. And then the giant cell tumor is just the type that stays in the bone and just destroys the bone. But it's the same situation. It's one of these blood cell structures that are rapidly reproducing. And then joints. And I know there's a typo in here, and I'm going to catch it and help you fix it. So we just have to watch, because I forgot to fix it before I came in. All right. So inflammatory versus non-inflammatory joint disease. The difference is the inflammation. So the signs of the inflammatory is that the joints will actually swell up. Where the non-inflammatory, the joints will actually start getting irritation, they get pain, but usually it's because of movement. Inflammatory diseases, they're swollen almost 24/7. The best way to identify whether it's an inflammatory or non-inflammatory is when they wake up in the morning. If they wake up in the morning and they're feeling fine, then it's probably a non-inflammatory. Why? Because they've just rested it for 8 hours, right? It's had a chance to relax, feel a little bit, feel more comfortable. If it's inflammatory, the immune system didn't shut down, so it's constantly causing inflammation. So we talked about the two major types. You're going to have rheumatoid arthritis and osteoarthritis. Rheumatoid arthritis, you can see in this picture, it's inflamed. This is the one that's actually an autoimmune disorder. The joints swell. Osteoarthritis, though, you can see that the bone is actually rubbing on the other bone. What has worn off here? The hyaline cartilage, yeah, the joint cartilage, the tubular cartilage is worn down.
But osteo, you do get that swelling. It's a swelling rather.
They get a little swelling after a lot of use. So after a lot of use and using it, you're increasing the blood flow there. But yeah, so there's technically some inflammation, but it's not considered inflammatory. Yep, and I'll show you some pictures. That's different than this one, yeah. Okay. All right, I think this is the one that's a problem. So, inflammatory joint disease is not called osteoarthritis. It's called rheumatoid arthritis. So this is a slide that was actually out of place. I forgot to rearrange. But an inflammatory joint disease, osteoarthritis, is characterized by the inflammation or the destruction of the synovial tissue, not the articular cartilage. It's actually the synovial fluid is leaking excessively and it's causing swelling. If it's worn down articular cartilage, then it's osteoarthritis. I'll show you the picture again.
Okay, so that says or, and you should say not.
If it's the articular cartilage that's getting attacked, it's the autoimmune. It's the body attacking it, which it's kind of. Yep, it is.
Oh.
Yep. With the immune system, you're going to expect some of the same things you see when the immune system goes to be active. Fever, you see more leukocytes in the bloodstream. You don't see that with osteoarthritis. So on this slide, the slide's kind of out of place, and you definitely want to cross off osteoarthritis and write rheumatoid up there. So everything on this slide is correct except that word osteoarthritis. This is rheumatoid. And then it can be infectious or non-infectious. Infectious, when you think of infectious, you want to think of that molecular mimicry. There's something that got in their body at one time and it kind of triggered this response in their body to attack themselves. Non-infectious, they just lost tolerance to self. Either way, their body or their immune system's attacking themselves. The next one's osteoarthritis, and this is where you're literally degenerating the articular cartilage. You're wearing it down. Let's say you're a marathon runner. You've been doing it for years and years and years. As you get older, that wear and tear on your knees, you're going to get arthritis in your knees. osteoarthritis. If you're a tennis player, where are you probably going to get osteoarthritis? Wrist and elbow, right? So typically it's wrist and elbow. If you've been working with your hands and doing things all of your life like this, where are you most likely going to get it? In your fingers and joints, right? It's wear and tear. Yep, osteoarthritis is based on wear and tear. There can be some genetic components where you just have weak articular cartilage and it wears down faster than normal, but it's still some kind of wear and tear. It's referred to a degenerative joint disease because it's always getting worse and never gets better. It's like when we talked about degenerative diseases with the nervous system. It's progressively getting worse. You can't reverse that. When the articular cartilage is worn off, it doesn't just miraculously appear again. So as we get older in age, when the primary cause is idiopathic, which we know it's wear and tear, but we don't know exactly what causes one marathon runner's joints to get osteoarthritis where the next one doesn't. So there's got to be some kind of a genetic disposition there. Right? And then when you look at this, one way to identify osteoarthritis is where is it affecting? If it's only affecting the elbow joint and the wrist joint on the right arm, is it more likely to be an autoimmune disease or because of something specific? It's osteoarthritis. It's specific because of something they've been doing to this arm. If it's evenly, like bilateral across their body, what would you suspect? Yeah, the autoimmune, which is rheumatoid. But if this one, if they've been, my knees have been achy or whatever, and they were in a car accident, they slammed both their knees into the dash, then you know exactly what it was. It's isolated to those two joints, and you know the damage caused it. But with osteoarthritis, they get pain, they get stiffness, they get enlargement of the joint when they've been using it. So at the end of the day, they come home from work and they're like, their joints are swollen, they sit down and relax. They go to bed that night, they wake up the next morning and they're fine. Everything's okay. They've got some relaxed, no inflammation around the joints, their joints feel better. And then after a while, you can actually see some deformity, and I'll show you the picture still. So there's just evolution of osteoarthritis. You can see it starts with normal, healthy tissue, articular cartilage, which is hyaline cartilage, and then eventually it wears off, and you get these little things called osteophytes, which are little chips that are coming off of the end of the bone as it's wearing and tearing. And I think of it like those osteophytes are like sandpaper in there. They're sand in between the gears. They're slowly going to wear down the gears even more. Typical symptoms, pain with use. They get swelling or stiffness after use. Weather has a tendency to cause irritation here too. They get bony nodes. And it's basically from a little bit of scar tissue. And I'll show you the pictures again. And then a lot of times they get back and neck pain because of whatever the wear and tear was. It's like, if they get osteoarthritis in their knees, they're eventually going to get it in their back too. Because whatever's causing that impact in their knees is often distributed through the back. It's not as intensely. Bless you. And then how they treat that, things like non-steroidal anti-inflammatories. And they take that after the long day of work to take down the swelling. And then exercise isn't like intense marathon running. It's movement of the joint trying to help lubricate it, but low stress. So where do they usually have them exercise at? In the water. Yep. So it's just not so much pressure on the joints, but they get lubrication moving back and forth. You want circulation there because that synovial fluid, by the way, is just cleaned up plasma. It's filtered plasma. So the more blood flow you get through that area, the more plasma starts secreting in there for reducing friction and lubricating the joint. So here's another example when you look at the hip. So wear and tear at the hip, you can see the hyoid cartilage is more off the head of the femur, and even the acetabulum is falling down. So it's just eroding away. And then here's an example. So you have these nodules, these little bit of scar out on the outside in the nodule, but a lot of it's compressed joint. It's holding out the sides instead of being lengthened. So finger length is actually a little bit less, a little smaller because the skin is retracted. But you can see the different nodules all over the place. And then I'll show you a picture of rheumatoid to compare to also. Yep, this is osteoarthritis. So they call them Bouchard's or Heberty nodules, but they look like. And they're not inflammatory swelling. When they bulge out a little bit like that, it's not technically swelling, it's accumulation of tissue. I've never heard somebody say it more painful. Pain is subjective, right? So, I bet it's way more annoying too because it's constant all the time. Right, and then rheumatoid, like I said, that one slide back there is kind of out of place, but this is definitely inflammatory disease, and it's because of autoimmune. It's your body attacking your own body. So one of the ways they identify this is they can actually look for those autoimmune factors. They can look for the antibodies in the system. So they're called RA, rheumatoid arthritis factors, or RF, rheumatoid factors. And they're antibodies. And here's kind of the pathogenesis. So what happens is that your immune system gets into the joint. And so it's attacking the walls that are surrounding the joint. So it can attack primarily the synovial wall, but it can also attack the articular cartilage. And then it starts accumulating this stuff called pannus. It's basically a scar layer. So it just keeps accumulating and accumulating. But all this inflammatory factor comes in. It moves in, it starts filling up the synovial space, and starts attracting more water, and you get more and more swelling. More and more scar tissue around the outside. And it causes these like tremendous swelled joints. I'll show you. Oops, did you have a question?
No, I
okay.
said it way more than
And then I already talked about this, so we're not going to spend much time on it. But the pathogenesis is that the immune system attacks a joint. It increases blood flow to that area. It increases making plasma. The plasma keeps pushing in and causes that synovial joint to swell up. The more it swells, the more it's going to do what? What damage where the two bones don't align with each other properly? Sublux or dislocate the joint. So you're going to see a lot more of the subluxation or movement at the joints. So it looks more like this. So we talked about the node before, but look at the actual fingers, the alignment of the fingers. They call it ulnar deviation or ulnar drift because they start shifting out like this. They start bending at the joint. I think I faked that. And then you see all these little fluid pockets that are accumulating here too. So those are two common signs of rheumatoid. The ulnar shift. Did I skip over a slide? I did. So here's how they evaluate it. If they have 4 or more of the following, they're classified as rheumatoid. So they can actually test them for those rheumatoid antibodies. Okay. If they have morning stiffness that lasts at least an hour, like you see up here, the immune system's been working all night. There's still swollen joints in the morning. If it's 3 or more joint areas, because if you have damage, like let's say to the knees from running, there are 2 joints. If you have damage to the wrist, the elbow, and the shoulder from tennis, that's 3 joints, but it's all located in the same strip. If you have 3 randomly placed joints, then you've got problems. Arthritis of the hand joints, especially the fingers. If it's symmetric, does symmetric absolutely mean it's rheumatoid? So if it's both knees, does it have to be rheumatoid? No, it's still be osteo. It's the combination of any 4 of these things. So they're classifying, is it arthritis, and then is it rheumatoid? That's why you need 4. And then radiographic changes, you can take x-rays, and like you can see here, you can see clear changes. Look at the bones. So there's the second digit. There's your metaphalanges going into the proximal phalanges here. You can see that that's almost borderline like dislocated, not just sublux, but dislocated. But they lose alignment. And then here's a comparison of the 2 hands. So osteoarthritis over there on the left side of the screen and rheumatoid on the right side. You can see, this is definitely swollen. Swelling. Where this, you can actually see it's kind of shrunken here from the larger the joints. And there are the cartoons from your book to go along with it. For the treatment for that, they could take steroids to decrease the inflammation because it's it's dumbing down their immune system again. Okay, and then ankylosing spondylitis. We kind of talked about this last week with the spine, but Here you can see you get irritation, inflammation between the vertebra, and then the vertebra, what they do is they just fuse. And then I think I mentioned Mick Mars from Motley Crue, but he's had it for decades, and that's why he's always like this. They call it bamboo spine because as these things fuse together, they actually start getting really, really straight. But she still has the same arch in the upper back, so the kyphotic arch, but he's lost his lordotic arch. So it's not that he's actually hunching over intentionally, it's that this arch is still intact, that I just straighten this one out. The other one looks more pronounced. So bamboo spine, it looks kind of like. Yeah, maybe if she's been doing that since way before osteoarthritis and menopause, it could do it. You can see that they're fusing together along here and they're straight. They call it bamboo spine because it looks like they've got a stick of bamboo straight up their spine, pulling them straight up in position. And it usually starts with lower back pain, stiffness, joint pains in the lower back, and then as that irritation starts healing, it's kind of like when we were talking about that myelitis, osteopenia, where all of that connective tissue starts turning into bone and just fuses everything together. I used to work for somebody that we did pain research together. She had so much back pain from being a horseback rider when she was younger that this started happening to her. And she actually had extra vertebra in her back, so it was not only was it straightening out and stiffening out, but it was making her harder to move because she had that extra vertebra in there too. And then you can see the progression. So the last slide just words it out, but it starts with inflammation. Then the immune system comes in. It's almost like the immune system's overreacting. It's going, oh my gosh, this is so terrible. You know, this is so much damage. It just fuses everything together. So that's what it does. It just fuses everything together. Ankylosing Spondylitis. Next one, joint disease, gout. Gout revolves around protein. And when I say that, things like high protein diet, high protein processing in the body. But when you start breaking apart proteins, you release the nucleic acids into the bloodstream. They used to call this the disease of kings because kings would get gout because they really high protein diet, really rich in protein. When you break it down, you release all these nucleic acids through your bloodstream, and the nucleic acids can actually be processed and turned into something called uric acid, which is one you want to up there somewhere. Should be in there. Oh yeah, you probably want to underline or write down uric acid because it starts as protein. As the protein's broken down in the body, whether it's from digestion or just metabolism in your body, breaking down muscles and rebuilding them, you start making all this uric acid. Uric acid is normally cleared by the kidneys really easy, but what happens as you age? Your kidneys don't work as well as they used to, so you can't clear this uric acid. So as these people eating high protein diets, as they age, they can't get rid of all that uric acid. This is the tricky thing about uric acid, is when it's cooled, when it drops just a couple degrees below body temperature, normal body temperature, then it starts turning into crystals. So it starts crystallizing. When people get gout, it starts crystallizing at the parts of the body that are the coolest parts of the body. So where do they start crystallizing? Yeah, fingers and toes. So a lot of times, that's why when people go to bed at night and they get up in the morning, they're like, oh man, their gout's acting up in their feet. Because in the night, it's cold at night, and their body temperature did what? It dropped. So they start getting this crystallized uric acid, or uric acid crystals, and they're doing something they call that gouty arthritis. And I'll actually show you a picture. They look like little white crystals. You could slice it open and the crystals would come out. And they call those tophi. We'll talk about it. But typically this happens after like 40 or 50 years of age. As your kidney function starts decreasing, you start increasing the risk of gout. And there you can see some swelling. So at the toe, at the finger. And you can see the uric acid crystals all accumulating in the joint. And then that bump is actually called a profile. You can slice it open, you can pull out the crystals, but then you just damage the joint.
So once those crystals are formed,
they can go away again, but it takes a lot of work to break them down. And there's some chemicals you can take to break them down faster. But yeah, if you've got the crystals and you start moving that joint, the time that it takes to move the joint versus break them down and slowly reabsorb them, it's like having crystals inside your joints, rubbing each other, scratching things. Okay, and then this is just kind of an explanation. Like I said, the crystals are actually because of protein metabolism. It's the nucleic acids that are in the protein, and as you break them down, you start releasing into the system. People that get gout either have faster protein breakdown or they get higher protein in their diet, and their kidneys just can't keep up with it. And then I already mentioned what happens that forms the crystals, what changes. So you have all this uric acid, but what actually happens to make it into crystals? Yeah, core temperature. So lower body temperature, change of pH could do it too. And then there are 3 clinical stages. This first one's called asymptomatic hyperuricemia. So they take a blood sample and they see that there's high uric acid. So when you go in for that 40-year checkup, they start checking things like your uric acid levels. And if it's high, but you're not showing any painful symptoms, no joint issues, then it's just called asymptomatic hyperuricemia, which means they're going to put you on a low what diet? Yep, a low protein diet. They're going to start restricting your protein intake. Right. And then the next phase is when it gets high enough that you start waking up in the morning and you start feeling that ache in the joints around the toes. You may not be able to see it yet, but you can feel the tension, you can feel the ache. Then you're at the level where it's not asymptomatic anymore. Now it's acute gouty arthritis, which means it sets on really quick overnight. And then the third one's when you can actually see those tophi, those little bumps. 3 symptoms. Usually there's about a 3-year phase in between transitions. So from the time they first start seeing hyperuricemia, it takes about 3 years before you start seeing the tophi start occurring. And then I just put a flow chart in here that you can look at. So either high purine synthesis, body doing a lot of metabolism, or high protein diet. Either way, it breaks down the nucleic acids, turning to uric acid, and the uric acid cause problems because it can't get out of the kidney, so it starts sticking inside the wall of the joints. All right. Muscle disorders, winding down. So the first one's contracture, and we talked about this before. Contracture actually has dual terms. One is that when you have like burns, what was contracture when it referred to the burns? They weren't able to do what? They weren't able to stretch full range of motion, right? So with that type of contracture, they can't get full range of motion because the skin actually healed improperly. But another form of contraction is muscle contraction. So this would be like a spasm. The muscles contract without an action potential. There's no signal from the brain going down to tell it to do it. It just starts doing it. You ever had those little where you can feel the twitches? You can actually, sometimes in your leg, you can see them going. That would be an example of contraction. So it can be because of electrolyte imbalances, sodium, potassium, chloride, calcium, magnesium, any of those things. Or ischemia to that tissue where the tissue's not getting proper oxygen and they can't run the mitochondria to make ATP. Lots of little causes. Yeah, some medications can cause it too. And then this bottom one's terrible. Stress-induced muscle tension. A lot of people carry their tension. You carry stress physically. You get stressed out and you get anxiety, right? So your heart, your blood, all that stuff starts changing. But a lot of people actually tense their shoulders. And they tighten muscles in different parts of their body. Maybe their shoulders, their legs. As a massage therapist, I got a lot of clients that I loved that they were stressed out because they constantly come back to me every week because they have tension. And you can actually feel the tension in their back and their shoulders. Sitting in a computer all day, you're tense like this. Your trapezoids are up like this, tense, right? So after working in a computer all day, you've got this stress-induced muscle tension. Stress can cause clenching of the teeth and causes things like TMJ, which is temporomandibular joint disorder. So they clench constantly. They get the masseter going, they have the temporalis going up here, and they're constantly tension. So it's associated with anxiety. That's why God created beer, right? Okay. All right, next problem, disuse atrophy. And when are you usually going to see this? Think about it. Muscles atrophy because they haven't been used. when people have their arm or leg in something that they can't use it? Cast. So a lot of times you see this with casting. You can't use the arm, so if your muscle's not working, your body goes, oh, we don't need that, and it just doesn't use it. It's disuse atrophy. You pull the cast off, and suddenly this arm's way smaller than the other one. So bed rest. Even when astronauts used to go up in space, I hate it when they give away magic tricks, right? So astronauts, when I was a kid, they'd come back down, and they'd always advertise or publicize the landing on television, where you see the astronauts come walking off the space shuttle, and that was crap. Because they actually had landed a week or 2 weeks before, but if they'd been up in space for an extended amount of time, what was happening to their muscles? They're atrophying. They didn't have to resist gravity, right? So it took no effort to move around. So when they come down to Earth after they've been up there for a long time, then they'd actually have to wheelchair them off the space shuttle because they couldn't move. They couldn't resist gravity very well. It was like staggering. And then what they would do is put them through physical therapy for a few weeks, build up their muscle strength, put them back on the shuttle, all fully clothed, and then videotape them coming off, and then play it for all us ignorant kids to watch and go, oh, wow, look at that. Government. Being deceived by the man. Okay, so things like bed rest, trauma, casting, nerve damage. Same thing with nerve damage. The first week of class, I showed you a picture of the guy that had nerve severed in his arm and he couldn't move his arm. His arm was all there. It was still alive, but he couldn't move it. So what happened to the muscle mass in his arm? Yeah, just atrophy. So it shrunk down because you couldn't use it. If you don't use it, it shrinks down. Okay, so treatment, you can do all kinds of things like isometric movements, passive lengthening exercises. So even if they can't intentionally move it, we can help them do things. And then myasthenia gravis. This is, I think, the third time we've talked about this disease. So I tried to put it all in one slide here. I think it's all in one slide. Maybe it's two. But myasthenia gravis, when you look at it, you want to remember again, what kind of disorder is it? It's a neuromuscular disorder. What's causing it? Autoimmune. It's an autoimmune disorder. And it's their bodies attacking the receptors for what chemical? Acetylcholine. Yep. So the B cells make lots of antibodies that go to the receptors for acetylcholine, destroys the receptors, and then they can't contract the muscles properly. So their signs and symptoms revolve around muscle weakness. Muscle weakness, quick fatigue. Usually in the smaller muscles are where you see it first, so like the eyelids, the lower face, they get kind of a sag to the face, they get the droop on the eye. And even though it says myasthenia gravis, usually it's not fatal, but there are some fatal situations. So some are more acute and it comes on really quick and then it can cause fatalities. What muscles would you have to worry about causing fatalities through? Respiratory, yeah? So it affects skeletal muscle, and you have to worry about it affecting the respiratory muscles. And then before the 1970s, about 1 in 3 would die eventually because of myasthenia gravis. So eventually. But now we actually treat them with this stuff called anti-choline esterase. So it attacks acetylcholine esterase, which eats apart acetylcholine. Acetylcholine lets you contract the muscle. When you're done contracting the muscle, this acetylcholine esterase will attack it, destroy it, so it shuts off the muscle. So if somebody has myasthenia gravis, they don't have enough receptors, we need to get more acetylcholine in their junctions. So what we do, let them release the acetylcholine, but we stop the thing that breaks apart the acetylcholine. If you just dump acetylcholine in their system, it will go everywhere. It will cause lots of side effects because acetylcholine is associated with what autonomic nervous system? Sympathetic or parasympathetic? Parasympathetic. If you want to try this at home, you can actually take a chemical that is an acetylcholine, or acts like acetylcholine. It's in eye drops. You can take it and you can put it in your eye. It makes your eye water. It actually makes you drool a little bit if it gets down in your nose. It makes your runny nose and everything. If you eat it or swallow it, it gets into your GI tract. And what's the parasympathetic system do? Slow down the GI or speed it up? Speeds it up. So you're taking an acetylcholine that looks like the parasympathetic system is going turn up, turn up, turn up. So it makes you nauseous, makes your stomach, makes your GI tract want to push things through quicker. So when people eat, if you've ever seen Wedding Crashers and they put the eye drops in the guy's drink, it's making his stomach irritated, making it want to vomit back up. It's making his lower GI tract diarrhea because it's overexciting that. Nerve gas is the same thing. They call it sludge. salivate, lacrimate, urinate, defecate, GI upset, and emesis. What's emesis? Vomiting. It makes you do all those things. So this acetylcholine, you can't just dump it in their bloodstream because it goes everywhere. What you do is you give them an anti-acetylcholinesterase chemical that blocks the acetylcholinesterase that breaks down acetylcholine. So it's isolated to just specific areas. It's kind of a cool process when you think about it. Right? So this thing, if they're going into crisis, it can affect their breathing. With crisis, if they actually have too much of this antibody and it completely shuts off their muscle contractions, it's a crisis. The respiratory system's going to shut down. So that's what they call myasthenia crisis. And fibromyalgia. I hate talking about this because there's so much controversy. Is this a subjective or objective disease? Subjective. It's extremely subjective. When I was studying pain, it's one of those diseases that we can't actually say, oh, you absolutely have fibromyalgia because we can see it. We have to ask them questions. Can people lie? Yeah, people lie. So you never know. And that's why when fibromyalgia was first being labeled, people were like, oh, that's not even a real disease because you can't pinpoint it. But nowadays, we're actually finding there are some physical characteristics. Like one characteristic is its relationship with serotonin. So they find that people with fibromyalgia actually have lower serotonin levels in their brain. Serotonin is associated with pain. Serotonin also helps you control pain. So they think that might be one of the problems. So what kind of drug would somebody take if they had fibromyalgia that they find actually helps fibromyalgia patients? Yep, SSRIs, selective serotonin reuptake inhibitors. So people can actually take SSRIs for pain relief too. In situations like this, that serotonin will actually block the pain signal. So general piece of information, about 3% of the population are affected, and it's primarily women. And I don't know that it's just affecting women. I think that it's actually probably affecting about the same number of men, but men we're taught, tough it out, you don't complain about pain. So that could be it. It's combined with sleep disorders, which you should probably know from the lecture video I had you watch last week. What would this have to do with sleep? Serotonin again. Yeah, serotonin. So serotonin and melatonin. Serotonin, if you take it and you break a little piece of it off, you have melatonin. So a lot of times serotonin problems are associated with melatonin problems too. But that's interesting because they find there are a lot of sleep disorders that are associated with fibromyalgia too, and it's probably because of the same chemical. So it's kind of a mix of sleep, endocrine, pain, neurotransmitter disorders. And then when you look at them going through an EEG, you see there's no stage 4 sleep. So they always feel tired, fatigued. And then here's kind of the key. Here's how they actually identify it, is because of these things called tender points. There are actually 18 tender points, 9 pairs, so 9 on each side of the body, but 18 altogether. And they touch here, they touch there, they touch there, they touch there. And if the person has pain in those areas, then they'll label it. What's the problem with that? Thanks to the internet, everybody knows exactly where those tender points are. So if they want to fake fibromyalgia to get pain meds, they can, right? They say, oh, that hurts. Yeah, that hurts. Ooh. Yeah, any of us could yank a tear if we really wanted to, right? Oh, my. So that's why I hate talking about fibromyalgia, is because it's subjective. People lie. People lie about it. I don't not believe that there's this disease, but they can be faked so easily they cause a lot of problems, especially people that are pain med seekers. But how they diagnose it right now are because of those 9 tender points, and then I'm kind of running down on time, but I showed the serotonin, endorphins, substance P, all these chemicals that have a relationship. And they all have relationships with the pain pathway, and serotonin is interesting because it also is associated with sleep. So that's why they think the overlap of fatigue syndromes and sleep syndromes, and also GI syndromes. Serotonin has a huge influence on your GI tract. But here are the qualifying, so how do they diagnose it? There are tender points, there are 9 different pairs of tender points, and by feeling like those tender points, they diagnose whether they have it or not. So how they rule it out is making sure there's no other problem exclusively. So the tiredness, the pain, it could be what kind of pain that could be deep that's sent out to the surface of the body? The R word. Referred pain. Yeah, so they want to make sure it's not something like a referred pain. Like, if the kidneys have problems, they refer pain to the back, which is going to trigger some of those tender points. CFS is chronic fatigue syndrome. TMJ is temporomandibular joint disorder. Irritable bowel. And temporomandibular joint. It's when those people clench too much and they get that joint issue. And then depression is also a common complication. Why? Because if we keep going back to serotonin, yep, most people take SSRIs not for pain but for depression. Yep, it's because of serotonin levels in their brain. So, yeah, actually, it could be a psychologically induced depression instead of physiologically induced. So yeah, if you're feeling pain all the time, you're going to be down a lot. But depression is a common complication. If you look at the serotonin philosophy or theory, then it explains it perfectly. You have low serotonin, which makes you feel more pain sensations. It also causes depression. So treatment, managing the symptoms, helping them get more nutrition, nutrients, sleep, exercise. Getting sunlight actually helps. Seasonal affective disorder. Reducing stress, and then taking the antidepressants like SSRIs. And then I am going to actually drop these last. Let me make sure. This slide's important. I was going to say the last one is not so bad, but these are getting in persnickety details that you don't have to worry about like this. So other myopathies, you'd have metabolic myopathies, which means there's some kind of metabolism issue going on. If you've ever seen Extraordinary Circumstances, I think, with Harrison Ford and Brendan Fraser, anybody ever seen that? That's Gene Hackman. Extraordinary something. You have to Google it, but it's about Brendan Fraser has 2 kids with this disorder called Pompe's disease, where the metabolism inside the muscle doesn't work properly, so they build up too much acid, right? Or acid. They build up too much toxin inside of there because they can't process small tastes of sugar appropriately, and it causes so that their muscles, the muscle cells themselves bulge, but they can't contract properly, so they get muscle weakness, and eventually they die. And Harrison Ford's a scientist, so I'm sure that ends up helping them because enough money is involved. But so you can have things inside the actual muscle that are causing problems. You can have inflammatory issues like poliomyelitis and myositis, which is polio. So polio is when you have inflammatory issues of the muscle and it causes damage or destruction. And polio also affects nerve fibers too. And then toxic myopathies like chemicals, and alcohol is actually the most common cause of toxic myopathies, alcoholism. Alcohol gets in your body and you just drink it and drink it and drink it, and it goes anywhere it wants. We drink it because we enjoy the sensation in the brain, the relaxing sensation, but it's shutting down neurons in the brain. It goes to the muscles and does the same thing. It can actually cause toxic buildup in the muscles. So those are the different groups. I think that was it. The only muscle tumor you have to worry about is rhabdomyosarcoma, which we talked about this 3rd week of class, but it's a muscle tumor of striated muscle. And that's it.